All right, here we go.
The broadcast is now starting. All attendees are in listen-only mode.
Greetings and thank you all for joining today's webinar. This is Rob Fromberg with Kaufman Hall, and presenting our webinar today are Walter Morrissey and Jenny Dulac from our clinical performance team. With more than 20 years of healthcare experience working as a clinician, strategic advisor, and administrator, Dr. Morrissey assists hospitals and health systems with clinical and physician alignment strategy and organizational transformation. Jenny Dulac has more than 35 years of clinical leadership experience, and her areas of expertise include quality management and clinical decision support. She has led clinical collaboratives for more than 250 hospitals and developed numerous quality and safety programs that have earned HealthGrade's Top 100 Hospital and Top 10 Health System designations. Before we start the presentation, I'd like to quickly review a few housekeeping items. All attendees are in listen-only mode for the duration of the webinar. If you're participating through your computer and have the ability to send questions to us, you may do so through the questions panel on your attendee interface. Just type in your question and click send. At the end of the presentation, we'll answer as many questions as we have time for. If your question is not addressed during the Q&A portion, we'll be sure to follow up with you afterward. Also note that the materials related to the issues we'll be covering today, including the presentation, are accessible in the handouts area of the attendee interface. And as a final note, today's webinar is being recorded. All registrants will receive a follow-up email later this week with a link to view the recording. With that, I will turn it over to Jenny Dulac.
Thank you, Rob, and thank you again to our attendees for joining us today. For our agenda today, we'd like to talk about why this, why now. It seems that it's a timely topic given the era of transition from volume to value. And secondly, we'd like to highlight how to use data to identify and quantify improvement opportunities using data-driven decision-making and how to move forward to really attack clinical variation. So let's pause for a moment to set the stage in terms of what's happening in our environment today. We have a perfect storm, so to speak, of reduced revenue and increased costs due to an aging population with chronic diseases and the emergence of disruptive technologies such as DNA sequencing. What else are we seeing across our spectrum? A restriction on our out-of-network coverage, high deductible plans, new payment plans from Medicare, with reimbursement pressures ever rising, higher drug costs, pension plan adjustments with folks such as UAW. And most recently in the Wall Street Journal, we see some of our major health systems such as Cleveland Clinic reporting a reduced $800 million over the last 4 years, reporting a 71% drop in operating income in 2016 to just $139 million. The Mayo Clinic, with their 2020 initiative and 400 projects aimed to squeezing cost and improving quality. So that takes us to the data slide where we're showing insurance spending growth rates declining for Medicare and private insurance. The average annual growth in per capita spending from 2000 to 2015 was 7+% of the spend in the first decade, compared to the last 5 years, where we see less than 1.5% for Medicare, 3% for private pay. For our U.S. medical cost and inflation, we are outstripping the cost of care, looking at the Consumer Price Index and changes since 2005. Staggering. So how does this translate into our organizations and specifically strategically in navigating the space that we find ourselves? We're addressing operational inefficiencies while trying to provide safe, effective care. And in order to do this, we really need to improve our clinical outcomes to maximize and optimize those reimbursements. We want to minimize or eliminate waste and unwarranted clinical variation while at the same time improving the quality of care through redesigning of our clinical processes and really moving that care across the continuum outside of our 4 acute care walls into our ambulatory environments. We also are working with our physicians on their physician preference items and wanting to look at how we can standardize those and hold those gains after we implement fewer preferences to reduce costs to those appropriate levels while balancing our strategic portfolio and right-sizing our physician preferences in order for them to optimize in their care delivery system. So what kind of data do we need to not only analyze, observe while we implement, and then continue to evaluate are through our clinical outcomes, utilization, and ongoing tracking and trending of data. This slide should not look too foreign to most of you in your specific areas, whether that's hospital or clinic. What we continue to see across the country is unintended clinical variation as it relates to clinical outcomes for our patients. Our physicians don't always know their own data. It's not transparent, it's not posted, it's not on an icon of their computer. And it's challenging to be able to identify the key priorities, the key measures to then track and trend over time to really monitor that quality cost equation. And most importantly, be able to demonstrate the ROI. How many of you are still trying to demonstrate ROI on your EMR implementations? So benchmarking is another opportunity which tends to be a black box and proprietary in nature, which we want to have in place in order to understand where we compare. Our physician preferences on the bottom line for quality, i.e. the power of the pen, most important to have the linking of the data appropriately attributed to the correct physician who is providing the majority of care. How many of you have seen a dashboard or your own physician report that says you've done 20 gallbladder surgeries, but you're really a primary care physician? And when we link our practice patterns with our intensivists, hospitalists, nocturnists, we need to be able to look at collective trends for those groups of practices as they do their handoffs in day-to-day care. And lastly, our large safety events are also important and will continue to be important in that process of care, which not only impact our outcomes, but we continue to see reimbursement and penalty consequences for rising safety events. In our next slide, we have our clinical variation value proposition then. So what? If we're going to improve our quality and outcomes while reducing cost, it actually enables us to deliver on that value proposition, because when we reduce those costs, we can then offer more affordable care to our community through not only charitable care, but most importantly, the pass-through through our payers. And when care becomes more affordable in our premium prices and contracting, we have better access to our network, to our providers, with and for our patients. And when our patients and new community members have access to the network, we achieve our goals as a community in really delivering the quality of care we're striving and to deliver and to attract for our community growth. With that, I'm going to turn it over to Walter, who's going to review the next set of slides. Walter?
Thank you, Jenny. As organizations grapple with many of the challenges that Jenny outlined, whether the macroeconomic pressures outlined with some of the consumer price index and Medicare inflation rates, to the challenges related to operating and driving to the level of performance necessary to to drive ongoing innovation and success in an organization, many organizations have already tackled low-hanging fruit. Historically, most organizations have been reluctant in those periods of strong revenue reimbursement growth to touch the so-called third rail of clinical variation, because ultimately that meant tackling many of those challenging conversations with your physicians. As those economic factors, the transparency factors, and ultimately the quality and outcome data that continues to become more prevalent, organizations have chosen that now is the time to identify, quantify, and ultimately attack clinical variation. Over the next portion of the webinar, we'll cover our recommended approach to identifying clinical variation. We'll provide some examples of the various analyses that need to be completed, and we'll outline a plan of attack for your organization to work with your physicians, your nurses, other providers to drive organizational performance and meet the care delivery needs of our communities. Jenny did a nice job talking about why we need to address clinical variation and that link between volume, quality, and outcomes. But here we move into the how. And we think it's critically important to spend time up front on that first task of conducting a comprehensive assessment. What are your opportunities? Where are those opportunities? What is the magnitude from a cost standpoint? What is the magnitude from a quality standpoint? After completing that comprehensive assessment and working hard through those data and analytics, that enables an organization to prioritize and move into implementation planning and monitoring. Ultimately, clinical variation is not a project, but an ongoing organizational activity that will move from clinical condition to clinical condition and continue to drive performance improvement across those areas of care. We believe that the bar for clinical variation needs to be continually raised as literature evolves, as we learn from our best practices, and we experiment around the best ways to most effectively care for our patients. We also believe that it's important to include benchmarking. We recognize many organizations are comfortable with benchmarking on a traditional labor or productivity effort, perhaps on the supply or revenue cycle ends as well, but we believe that also can apply on the clinical variation front. We would emphasize that you need both internal and external benchmarks to help navigate those challenges that Jenny mentioned around physicians not knowing their data. Regarding external benchmarking, we think it's critically important to start there, to understand where your organization performs relative to peers or relative to aspirational organizations. We recognize that many hospitals and health systems have variable sites of care, some with small operations, less than 100 beds, less than 50 beds, to large medical centers in excess of 500 beds. Obviously, that external benchmarking must be peer group based, but also importantly, it must be risk and severity adjusted. The first set of complaints we get are, my patients are different. I always get the sickest. It's critical both on the external and internal side to ensure that you are risk and severity adjusting your benchmarks in order to take that first pass at navigating the typical physician or provider challenge of my patients are different. We ultimately believe that internal benchmarking is critical to drive physician behavior. When you move beyond the external benchmarks, which can be used to identify areas of opportunity, and then begin comparing within your organization, how do the various physicians perform, whether it's on length of stay, whether it's on cost per admission, whether it's ICU utilization within those stays. We also see extensive internal benchmarking opportunities around pharmacy and imaging utilization, which drugs we choose, how often we get diagnostic testing, and ultimately that internal comparison in partnership with national literature and leading practice can drive that behavioral change. So as we think about this first task and completing a clinical variation assessment, it's really a series of peels of the onion. It's that first external benchmarking opportunity to look for your preliminary opportunities where you have unfavorable comparisons to national, regional, and peer benchmarks that allows you to further prioritize and dive deeper into what exactly are those opportunities. I like to look at this first circle as the preliminary opportunity as a way to start with external benchmarking, but then that second task within that to be that opportunity refinement and physician-by-physician comparison. What are your top performing physicians versus the rest of the medical staff for those types of care processes and clinical conditions? Logically, that moves it towards action plan development and prioritization, which allows you to head towards task 2. Ultimately, at the end of an assessment, those key outputs at the bottom of the page are most important. There has to be a summary level of report that spans the organization, whether those be length of stay, imaging utilization, ICU utilization, down into a detailed review at the clinical condition level. How do we perform for sepsis? How do we perform in joint care? And a whole list of medically related medical and surgical conditions that document both cost and quality improvements. That assessment must complete detailed comparative physician information and ultimately result in that prioritized opportunities for sequence design and implementation. A few elements that we think are important within the preliminary assessment is we believe you must do it from both a top-down and a bottom-up approach. The top-down approach begins with clinical documentation and coding. It covers many of the major quality and safety processes, whether it's hospital-acquired conditions, patient safety indicators, as well as the clinical processes. How much ICU do we use? What's our length of stay? How much diagnostic cardiology or pharmacy services are we utilizing? That top-down approach allows you to understand what are some of the major organizational issues that must be addressed to drive successful implementation, whether that's length of stay related to discharge planning and nursing home disposition, to keeping patients in-house to get diagnostic tests that can be performed as an outpatient. Those macro top-down organization-wide opportunities need to be addressed from that top-down in order to have success in your bottom-up efforts. When we talk about bottom-up efforts, there's an example: sepsis, cardiovascular subspecialties, neurosciences, total joint. We think it is critically important to begin and drive physician and nursing change at the clinical condition level. And that assessment will be able to provide how are you performing for 20, 30 key clinical conditions that completes and rounds out that assessment. For a few examples, I'll let Jenny walk you through and make that assessment more tangible.
Thank you, Walter. And as a very nice job of not just setting the stage on the how-to, but walking through the steps. Walter referenced benchmarking and how important that was in the preliminary analysis and identifying the opportunity. This slide really demonstrates an approach to looking at your organizational mortality rate. This is an example of mortality. However, you'd want to do this for all of your clinical outcomes, such as your morbidities or complication, your patient satisfaction, physician, provider satisfaction, and cost, to really make sure that you're looking at a balanced set of outcomes, not only in identifying your opportunities as a system or as a hospital or clinic, but most importantly, making sure as you move into that implementation phase that you don't inadvertently impact one of the other outcomes while trying to address, for example, length of stay. So while you're driving down length of stay, your patient and provider satisfaction levels dip because the processes haven't been inked and streamlined in a way that also provides for a powerful, positive experience. So in this specific example, we're looking at the traditional speedometer, color-coded, And first of all, we're looking at quartile performance to help us get started. This particular example is divided in color-coded to highlight those quartiles with the needle highlighting where your organization or system would fall. And in keeping with Walter's comment, all the data is severity adjusted to make sure you're speaking to that clinical voice around my patients are sicker, or I'm covering the house and all of my discharges were more complex, so it took me longer to round in that handoff from hospitalist to hospitalist. And lastly, if you notice in this slide, we've sourced the benchmarking data, the time period, the comparative customized peer group that Walter had mentioned, whether that is community to community, primary, secondary, tertiary market, academic to academic, whatever is most important to you that aligns strategically with your organization, and then annotated accordingly so that when you're utilizing these assessment tools from a data perspective, you have all of the answers to the questions that your audience will be asking about the data set. So as we move on to the next slide to look at another example of data graphics and top-down analytics as you're beginning that analysis and focusing on your areas of opportunity. This is an example of our patient safety events, which are important to track and trend as you move into a culture of safety and high reliability where we first cause no harm. We've also provided here a different type of comparative analysis where you are looking at the observed versus the expected, identified in the color coding, and most importantly, the cost overlay in the green dots, so you can begin to see bumped up against your comparative benchmark group where the opportunity really lies. It gives you a thermometer, so to speak, or a roadmap in terms of prioritizing and the distance that you have to go in your journey so that you can avoid those penalties in a value-based reimbursement environment and or maximize on that reimbursement. Another example I'd like to share with you is around the potentially preventable complications or comorbidities that your patients would experience from a hospitalization. It's not planned, but they happen. And in this example, you can see between $800,000 and $900,000 in the 3 diagnoses of septicemia, pulmonary edema, and shock, all very severe illnesses and consequences of the care that we deliver, and many times moving from a complication to an unwarranted mortality based on the processes of care and the delivery system at work with our providers in the environment that we care for our patients. I'd like to move on to another outcome indicator, which is really gaining popularity once again, in particular with the health plans around length of stay. As we're beginning to look at care management models again and recognize the importance of redesigning those care management models, I would challenge any of us to say we have that exactly right quite yet, in particular with the 2 midnight rule with our observation status and the impact that has on your reimbursement and your bottom line of your organizations. So in this particular example, we again have looked at length of stay with an overall lens through severity adjusted data and excluding the patient population that isn't part of the focused area for your initiative and or your particular hospital, and or to answer the question, what is the length of stay that we really want to move the needle on? So for example, we would exclude newborns. They come part and parcel with our patients. We may be excluding our psychiatric patients as an example, so that we really have a customized patient population or cohort of patients as we move through the data and analysis to respond to in prioritizing our initiatives. In the next slide, in my computer timed out, I've got it back. If we're going to focus on length of stay, it's helpful to know where the variation is within our clinical units. And as you all know, when you've been to one nursing clinical unit, you've been to one nursing clinical unit. The design of each unit usually differs. Supplies are in a different place. It may take longer to get from one patient to another, to traverse the hallways, etc. So in this particular slide, it allows us the opportunity to look at length of stay among the various clinical units based on the number of days we could reduce that patient length of stay across those units, bumped up against the physicians or providers in this case who are actually writing the orders on those clinical units. So in our implementation, we can focus in on a clinical unit, i.e. bottom up, or we can also focus horizontally across the organization as we begin to redesign our care management models. And next, taking that even a next step down, if we can't move our patients from our clinical units to discharge them in a timely way, we experience a bottleneck, which is not infrequent. So what are those discharge dispositions that we want to look carefully at to know where to focus that handoff or open up that availability, in particular if we are also running long-term care facilities and or have swing beds that we have more control of in those particular environments. So this slide enables us to look at that discharge status. It's not uncommon that we are waiting for beds in a skilled nursing facility. It's not uncommon to have the acuity bed that you need to transport your stroke or trauma victim to for respirator care, etc. And take a look at the days of opportunities all the way from 6,000 days down to 250 or 300 in our hospice home environment. It's a great accolade to hospice that we've opened up those number of beds over time. So now that we've looked at the system level top-down opportunities, I'd also like to look at the clinical service line. We've looked at system to hospital, and now we look at clinical service line as we cascade the data, but most importantly, we cascade the level of accountability in those typical clinical service lines that not only run our margins, but how we organize our physicians as well. So this slide shows us the area of practice, the clinical conditions specific to that service line, and combined with the physician analytics on variation, over a $3 million opportunity around clinical effectiveness efficiencies compared to that benchmarking group. And in this particular example, throughout the slide deck, we've used 50th percentile. However, looking at the clinical conditions specifically, which is how providers think about their patients and their practice, we have an opportunity to cascade down further to the condition level. We see in this particular slide our demographics, our severity of illness, and all clinical outcomes that are important to track and trend to that patient population, and they're pretty standard across all clinical service lines, in addition to the benchmarking opportunity, again to 50th percentile, color-coded for ease of calling that opportunity out. Now, we've used 50th percentile across the board to get us started in demonstrating these examples today. I think that would be important for the first year, perhaps the first 18 months, as you are beginning to get your initiatives in place. You are reaching a cadence, a momentum in terms of implementation. But as you move forward and continuing to reach that benchmark performance, in year 2 or 3, you would want to move that needle to the 75th percentile, to the 3rd and 4th year, the 90th percentile, so that by the time you have tracked and trended and finalized your implementation while holding the gains, you have reached above the 90th percentile in performance and find yourself in that top 100 hospital category in the upper decile of performance, coast to coast. And so this demonstrates how you can use the data not only to identify the opportunity, change the processes of care, evaluate the processes and outcomes, benchmarked in a competitive way and customized to your particular environment, but most importantly, to strategically align with where you want to be as one of the best practice hospitals across the country, not only to deliver that quality care, but to keep your house in order to stay in business in this day and age that we find ourselves in. And lastly, I want to close on this data section with a statistical process control chart example. Every one of the indicators we've looked at from a safety or an outcome perspective should also be shown on a weekly to a monthly basis in a control chart fashion. Why? Because the control chart methodology allows us to recognize the signals in the data. The goal is to minimize variation to the mean in order to poise yourself to make a dramatic change. And in this case of length of stay, you'd want to lower that mean. But by tracking and trending the data points and monitoring the signals of those points, it enables us to implement change more quickly. And more importantly, if we are off the rails, so to speak, as you see in the February 2014 example of this slide with a data point almost off the chart, it signals that something has occurred, which in this case was not good because of the magnitude and the impact of the length of stay for that particular month. That would warrant a deep dive into the patients that constituted that particular data point of that week to understand what was going on so that that situation could be remedied, rectified, or totally redesigned as it relates to your discharge, disposition, or your end-to-end processes of care from admission to discharge. So with that, I am going to turn it back to Walter.
As you can see, our assessment and belief for this first task, as I outlined earlier, is a very detailed dive into what are the opportunities across the organization. We've showed you organizational-wide opportunities like ICU, length of stay, mortality rates. Jenny mentioned patient satisfaction. We also started to show you some of the detail required around the various clinical conditions, some of which you see here on the slide in front of you. The other point we wanted to emphasize as you move from a very heavy analytic exercise and getting your source of truth to moving at the end of that first task or that assessment is towards prioritization. And within that context, we think the prioritization requires several dimensions, two of which you see here. You see that we pair on the horizontal axis, what's the composite of quality variance versus the dollar opportunity on the vertical axis. And this is one step in beginning to understand relatively how your various clinical conditions perform from a quality and cost opportunity that allows you to begin to prioritize where are you going to attack first. In this example, you can see that cardiac surgery in the upper left corner has a very high dollar impact, but also a pretty substantial quality opportunity. And when we use this type of analytics, this combination of analytics, as well as trying to incorporate some of the more subjective components, we begin to develop a roadmap for implementation. So as we think about prioritizing opportunities coming out of this assessment, there's 5 typical categories we look at. What's the strategic rationale? Is this right for the patient? Is it the right time? Where does it benefit our organization and where we're trying to go? The critical question, are the physicians engaged? Do we have somebody who can own and lead this initiative? While that cardiac surgery bubble that I showed on the previous slide may be a huge opportunity, without the appropriate physician leadership, that one's going to fall much lower down. I've alluded to the third and fourth elements here that we often look to tie quality and financial. together. We find that the physicians, nurses, and other providers do not embrace the change when it's just about the financial opportunity, nor when is it just about quality or ability to really drive without the finance. They need to go hand in hand, and we like to look at those. And ultimately, what are the political obstacles? Are there any major roadblocks beyond just the physician side that would make it difficult to accomplish that? So with that in mind, moving out of the assessment, we move towards that second task. This ultimately gets into detailed design and implementation. We think that after that 2-month assessment, typically, we move into a prioritized list of organizational-wide opportunities as well as clinical condition-specific opportunities. Maybe it's cardiac surgery that I mentioned. Maybe it is heart failure or sepsis. Ultimately, the analysis isn't done. As you prepare to work into developing reasonable, achievable, and sustainable implementation plans, there's going to be additional analyses required in order to set targets and ultimately monitor performance. This dives deeper into physician specifics. It dives deeper into nursing unit or discharge disposition alternatives, or ultimately allows us to understand some of the other linkages to our ambulatory and primary care components of care. With that analysis complete, we move into design. Obviously, within a traditional performance improvement approach, organizations are going to typically use and incorporate some of their standard skills and tools kits, whether they be lean or otherwise. But ultimately, we find it's important to design a prioritized list. For example, we worked with an organization who was working on their community-acquired pneumonia. And the physicians, nurses, and support services identified 15 different initiatives that were opportunities to streamline the care. The importance of the design phase is to quantify those opportunities, understand the operational implications, and ultimately prioritize and roadmap out initiatives so that they can be tracked and monitored in the future. At the same time, and that third bucket was the program infrastructure bucket that you now see on the bottom. We believe that as you move into this detailed design within clinical variation, that deep dive analysis takes 1 to 2 months, and then you work through detailed design sessions with your physicians, with your nurses, with your business analysts. All the while building a program infrastructure to not just track and monitor, but ultimately move on to the next clinical condition. As I mentioned earlier, typically we look at 20-plus clinical conditions for those opportunities and prioritize and sequence them. Most organizations, whether they be systems attacking this across multiple sites of care or standalone hospitals attacking it at just one site, organizationally cannot handle more than 1 or 2 starting at the same time, 6, 7, 8 over the course of the year. Many organizations choose to launch 2 clinical conditions each quarter and continue that in an ongoing way, in addition to tackling the global length of stay initiatives, discharge planning, pharmacy utilization, etc. These programs don't build the sustainability that you need without building the right program infrastructure. Developing consistency to the way that you perform analytics, to the way that you track and develop scorecards to monitor, to training the same type of people to perform and ensure that the process improvement activities build into the clinical space that the doctors and nurses often work in, yet don't have as deep of detailed knowledge of. With that, we'll cover with a few concluding remarks, and then we'll be happy to open it up for questions in 2 or 3 minutes.
As you're formulating your questions, I just wanted to take a few minutes to refer to the building blocks for success. While we have focused on the data component and the approach to clinical performance improvement, I think we would be remiss in not speaking to governance, infrastructure, and process as key opportunities that every organization would want to have in place as part of your performance improvement work. So of course you want your boards on board related to your governance of your organization. Number one, that's because it's their job. But most importantly, you want the transparency and visibility. And I would add that that also includes your data governance component in terms of working with your IT and executive leaders who really set the stage for that transition and communication between your board and your employees. Secondly, within the infrastructure, and Walter referred to this, we frequently see the dyad or the triad model depending on how your organization is structured. So at a minimum, the CMO with the CNO and hopefully the CQO, and how that translates and cascades throughout your organization, so that you would have your medical directors working with your nursing directors to really operationalize and track and trend those changes, and most importantly, utilizing actionable data, which is why we've spent the majority of the data presentation looking at graphics and signals in the data to point you to the place of action so you do not lose that momentum, so that you can maintain that bias for action so that people don't get burnt out, fatigued, they don't understand the priorities. Most importantly, they gain enthusiasm and engagement in the work as they become more data-driven in the changes that they encounter on a daily basis in their daily work on the clinical or department unit level. And resiliency is a key characteristic of not only our board members, our executives, but our providers in regards to delivering that care on a daily basis and being resilient to the many things that draw you away from the focus and or a mortality and or a sudden infant death or a patient safety experience. Learning, pulling yourself up by the bootstraps, acting on that adverse event quickly to redesign your process of care to impact that best quality outcome. So I'd like to thank you for your time and attention and turn it back to Rob, who's going to help us moderate any questions that you may have.
Thank you both very much. We have several excellent questions, and I will start with a question that addresses implementation. So Dr. Morrissey talked about a number of projects that could be done at the same time within the first year. But within that first year, what is a realistic number of initiatives that will see a measurable success, a measurable improvement?
Great question, and something I neglected to mention. I talked a fair amount about starting and how many you do, but did not talk really about how does that translate across. To work off a simple calendar year example, say at the end of 2017 you had completed your assessment, you were ready to go and launch some of this work in January of 2018. As I mentioned, we'd like to see at least 2 clinical condition-specific initiatives a quarter, which means you would launch one in January, typically launch one in February, and then restart that cycle in April and May. Often, we don't see realized gains for approximately 4 and more often 6 months after beginning the detailed design. While there may be a little bit of improvement while you're still going through the planning effort, we really believe it's going to take up to 6 months to come up with detailed, actionable, and trackable plans for success. Thus, those initiatives you started in January and February are now beginning to realize their improvements the second half of the year. And ultimately, we're talking about really difficult change. This is change in practice behavior. This is really challenging in more organizations than not, a historic way of doing things. And we often will say that that ramp up of total opportunity, say it was a $5 million opportunity in sepsis care, you may get $1 million to $2 million in that first year if you get out of the gates pretty quickly. But really aren't going to get to that 100% realization until the end of the second year. So I would make, back to my example, that would be if we started in January 2018, it would be late 2019 until you are at full target achievement. So a couple additional comments on that. Number one, we often see halo effect. So while you may think you have $5 million in opportunity in sepsis care, based on the work you've done, that's going to change other things that happen in the ICU and drive improvement. Additionally, when we think about clinical variation overall, this isn't a quick fix to an organization's cost positioning. While we would expect to get the quality gains a little bit quicker, the cost improvements that come with it often are a little bit slower. So great question. Thank you.
Great. Walter, you mentioned the often heard refrain of my patients are different, my patients are sicker, and we have a question here that I think speaks to that. And the question is, what are some tips and suggestions for getting physicians and clinicians to have faith in the data?
I think the first thing is partnership with them. Make them a partner as they work through it. You have to be very transparent about what's in the data, what's not in the data. Jenny mentioned some exclusions or typical exclusions. It's very important to show physicians how you have excluded outliers. While they often fall back on my patients are different, when you've showed them that you have excluded their outliers, whether it's 1 or 2 standard deviations away from the mean, they do remember that sometimes you get unlucky with a patient that spends 20 or 30 days in the hospital and consumes resources, or has that freak case within the care. When those are pulled out, when you show them that it is risk and severity adjusted, and when you show how their overall case mix or severity compares to their peers and show how their peers do it different, that partnership and that level of transparency usually drives to the place you'll be. I recognize there are some 5-10% who just are never going to get there, but we often find that you get a lot of momentum through partnership and with your physicians on the data.
Great. There's also a related question, which is, over time, what are best practices for communicating this data with physicians? And so I suspect what that's getting at are things like, how frequently do you show clinicians the data? What form do you use? Are there regular meetings? Are they individual conversations versus group conversations? Jenny, I suspect you've had a lot of experience with that. Do you have any thoughts?
Sure, and that's a great question. And picking up on Walter's calendar example, I would strongly recommend that you combine your performance data with your change strategies. And it's very effective to outline your change strategies for the coming year if you have 6 to 12 in mind for that first quarter, second quarter, throughout the year. You prioritize them over the 12 months, starting with the easiest to accomplish first. And then as you're adding those changes, they become more complex, and you have to continue to carry what you started in January through the end of the year and into that next year, as Walter alluded to, and tracking the data to correspond with those change initiatives so that you've identified your leadership team, the people who are driving the change, your targets in regards to your process or outcome measures, your change strategies, and then your data, so that the data has relevancy and is transparent. So for the teams that are actually working on the design or redesign work, it is not uncommon to have those folks meet on a weekly basis, especially as they're ramping up. They're looking at data, they're evaluating, they're analyzing, they're evaluating their change strategies and going to the next step. In regards to the organization as a whole, I would recommend at least monthly, whether that is through an email push, a published data set, all of your executive teams, starting with the board all the way down through your quality committees, your service lines, your physician departmental meetings, as is related to their particular work. And depending if you are an organization that has an electronic icon on your desk that you can pull the data versus having it pushed to you. Starting the work early on, I think it's very helpful to have an email push or a push strategy, whether it is printing the materials and posting on your clinical unit or physician office practice areas or the surgical lounge, so that the data is very transparent and, most importantly, is updated routinely, whether that is weekly with a control chart or monthly with the typical color-coded speedometer or dashboard. One of the fastest ways for people to lose interest is when they see the data posted that's 5 or 6 months old. So irrespective of which venue you choose or a combination of venues, the most important thing is to be consistent and manage the expectation for people to wait to see, to be anxious to see their data.
Great. Let's do two more questions. One refers to the top-down versus bottom-up concept that was presented in the webinar. And the question is, who is actually setting the goals for top-down initiatives and who is setting the goals for bottom-up initiatives?
Why don't I take that one, Rob? Thank you. Yes. I think I would argue it's the same team. We believe the right structure would have a clinical variation steering committee that has senior clinical executives, as Jenny mentioned, the dyad triad of CMO, CQO, CNO, that ultimately sets the goals and expectations around the quality and cost performance opportunities, whether they be top-down or bottom-up. Ultimately, execution is going to depend on, specialty-specific, condition-specific teams that will be responsible for owning the implementation. But we believe that target setting and identifying where the organization needs to push first has to start above, and that the directors, vice presidents, and clinicians, whether they be medical directors or otherwise, are responsible for hitting those goals within their own objectives. It does bring up a really good point that I neglected to mention during the webinar itself, is that we've seen strong organizations repurpose those classic medical director contracts away from, really a time-based stipend to clear performance-related bonuses or ties to efforts like this, your cardiovascular medical director being responsible for success in their angioplasty clinical condition work or CHF work. We think it's important to align those incentives lower down to achieve success. Great question again.
Thanks, and you anticipated another question about a more focused on accountability, so that's extremely helpful. So one last question, and this one may be brief, and that is that with the pervasive interest in cost, what is the level of involvement of the finance area of the organization?
If I might,
Yeah, go ahead, Jen.
I have a favorite vignette that I share about changing hats between the Chief Quality Officer and the Chief Finance Officer. And in our monthly meetings, we literally would do each other's presentations to show that the methodologies related to the data, the focus, the change, the trending of data, whether it was by run rate or control chart methodology, was inherently the same, and that in particular at the C-suite level, you should be able to exchange those data sets. And again, I mentioned the balanced set of outcomes and making sure that you're always looking at your cost component in combination with your morbidity, your mortality, your readmissions, your complications, and that patient-provider experience. So for us, it was always a combined group, starting with all 5 of the C's, and then down to the dyad, triad model, depending on your structure and your infrastructure. Walter, did you want to add to that?
No, I think that's great. They've got to be locked hand in hand.
Thank you very much. Thank you to all the attendees. Walter, if you advance to the next slide, you will see the contact information for the presenters and also a web address, kaufmanhall.com/peak to learn more. Thank you very much for your time. Again, in the handouts section of your interface, you can get these materials, and please don't hesitate to contact us with any questions. Have a great rest of your day.